morning. I'm Peter Stanton, publisher of the Worcester Business Journal, and I'm pleased to welcome all of you here to our annual Healthcare Forum. When we go about narrowing down the topic for this annual gathering, we try to make sure the focus is both timely and important to our business audience. And then we start looking for a keynote speaker and a panel of experts who can deliver the goods. Well, our topic today is a big, broad one. It's called Moving the Needle on Healthcare Costs. And I can't think of a better group to tease out this often vexing issue than the folks you will hear from this morning. Should be a real treat, and I'm sure you're all looking forward to that conversation. As you know, as I'm sure you can imagine, this kind of event doesn't happen without the contributions and support of many folks, and that includes our sponsors and our partners. So I'd like to give special thanks to, and the names will magically appear up on the big board here, our presenting sponsors, which include Fallon Health, the Reliant Medical Group, and UMass Memorial Healthcare. And to our supporting sponsors, Conover and Gould Strategy Group and Revelation Productions. We're going to have a few introductory or welcoming comments from our presenting sponsors, and I'd first like to invite up Dave Presick. Where'd you go, Dave? There he is. Who's the Senior VP and Chief Sales Officer at Fallon Health. David.
Thanks, Peter, and good morning and welcome to the Worcester Business Journal Healthcare Forum. Thanks to the Worcester Business Journal and the other sponsors, including Reliant Medical Group and UMass Memorial. And certainly welcome Assistant Secretary Dan Tsai. We appreciate you coming out and looking forward to your comments. So Fallon is celebrating 40 years this year, and I appreciate the support of many of you in this room. We currently serve about 250,000 people across the Commonwealth, including our commercial business, Medicare Advantage, our Navicare products, Summit Elder Care, Community Care, and of course, Medicaid, which is going to be a big portion of our discussion today. We provide services to about 36,000 Medicaid recipients. On March 1st of next year, that will jump to 80,000 through the ACO program that we're going to talk about today. And we are in the midst of launching 3 ACO partnerships, one with Reliant Medical Group, one with the Berkshire Health System, and one with WellForce, which is Lowell General, Hallmark Health, Tufts Medical Center, and the physicians associated with NEQA. So we're very interested in this topic. So just to emphasize how big this is, keep 2 numbers in your head today, right? And I'm sure those will be talked about today. 25 and 40. 25 of the folks that live in the Commonwealth are part of the Medicaid program. And close to 40% of the state's budget is spent on Medicaid. And the ACOs are meant to help better manage this. So those are 2 big numbers that we're going to talk about, I think, a fair amount today. So thank you all for attending, and we're looking forward to this discussion.
Thank you, David. And next, Linda Coca-Cola, the Chief Communications Officer for Reliant Medical Group.
Thanks, Peter. Good morning, everyone. I want to thank Worcester Business Journal, first of all, for actually creating this forum. I don't remember how many years, but I think Reliant Medical Group has been either a sponsor or a participant in some way or another since the very beginning. So thank you for creating this forum. As everyone here knows, healthcare touches everybody's lives. It's also incredibly complex, and you use the word vexing. There are vexing issues that we all have to address. Reliant Medical Group is really entering a transformative era. If you've been reading the newspapers, you might know that we're on the verge of opening up a lot of new sites over the next 2 years. We have invested dearly in manpower and otherwise to create healthcare settings that are efficient for patients, that are efficient for caregivers. We want to be a destination for both patients and medical talent. And one of the ways that you kind of create that kind of transformation is you address the tough issues and you innovate, and one of the ways we can do that is to have forums like this. We're actually talking about these very complex issues. So again, thank you everyone for being here and being part of this really important conversation, and thanks again to Worcester Business Journal for creating this forum for us. Thank you.
Thank you, Linda. And look who's ready. Judy Taylor Patel, the Vice President of Marketing and Communications of UMass Memorial Healthcare. Judy.
So good morning. Thank everybody for coming. I know you've already heard before, but I think it's really important that you're all joining us in this important conversation about how to best provide healthcare to our community. I want to give special thanks to Peter, the publisher of the Worcester Business Journal, and associate publisher Mark Murray, and Chris Prosser, the events and marketing manager of the Business Journal, for pulling this event together every year. It's truly a feat, and thank you. As the region's largest healthcare provider and also the largest employer, UMass Memorial is committed to leading and participating in innovative programs and new models that deliver high-quality healthcare at the lowest possible cost. There are a number of innovations that we've done throughout our organization over the course of the last particularly 4 years since Dr. Dickson took over, all around making it easier to access our services through services like our 855 UMass MD, which makes it one phone number that people can call from throughout the region, to innovative models and innovative treatment locations, partnering with many in the community to deliver all of these things, and we're committed to continuing that important work. Back to today, I also want to thank our fellow sponsors, Fallon Health and Reliant Medical Group, really our healthcare partners in this community. So thank you, and we continue to have the pleasure of working with you and together with you to take care of the people that we all serve. Want to also just acknowledge our presenting sponsors, Connor and Gill, and also Revelation Productions, important partners to us here as well. Thank you to our keynote speaker, Dan Tsai, and our distinguished panelists, all who will have interesting perspectives and a lot of expertise in the topic of accountable care. We look forward to participating in robust and meaningful dialogue today, and going forward, working together to deliver the best possible care to everybody in Central Massachusetts. Thank you.
Thank you, Judy. So it's my pleasure to be able to introduce our keynote speaker. Dan Tsai, as you all know, is the Assistant Secretary for MassHealth and the Medicaid Director for the Commonwealth. And he helps oversee, as David Prezek mentioned, a big budget, some $15 billion that the state spends on this Medicaid program, which covers that 25%, that 1 in 4 residents that we're talking about. It's interesting, Eric, I know with your $2.3 billion budget, often you're the biggest, organization in the room. And so Dan's number is, it's rare that there's one that's larger than that, but it's obviously a huge impact on all of us and on the state and on all the organizations that deliver healthcare in this region. So he's responsible for ensuring a robust and sustainable mass health program, which includes developing new policies, payment models, and operational processes that improve healthcare delivery to 1.8 million low and moderate income individuals and those with disabilities. Before joining HSS, Dan was a partner and leader in the McKinsey & Company's healthcare systems and service practice. So that's a brief intro. There's a longer one in the program, but I won't read it, and I'll have you come up right now if you would. Thank you very much. Dan Tsai.
Thank you. Good morning. Thanks for having me and for the panelists for, I'm sure will be an engaging set of discussions later this morning and following. Dave did mention 2 interesting numbers that I think is helpful context and that'll set a little bit of why we are doing this whole ACO thing, and I'll talk a little bit about what is ACO, what we're hoping to actually accomplish and achieve through that, and how we're hoping to partner with the community, with providers, with their plans, and many others. So we're actually a little higher than 25% now. We have about 1.9 million people on MassHealth on the Medicaid program, so it's about 29% of the Commonwealth. And our budget, to give you a sense of growth, the $15 billion was written when I started in January of 2015. We're now a little bit over $16 billion. From a cost standpoint, the challenge is real because we have grown over the historically at a multiple of what state revenue has grown at. So when you're 40% of the state budget and growing much faster than the state budget, it presents a very just practical challenge of how to maintain a sustainable system. And over the past 2 years, 2.5 years, we've substantially brought that growth down, but there are a lot of longer term things around the ACO that we're trying to achieve, and I'll talk about that in a little bit as well. So cost is certainly a major component from a practical reality standpoint. The other is from a care delivery standpoint. So I remember when the Secretary for Health and Human Services and I first started, she and I kind of split up and went across the whole state, talking to a bunch of communities, to providers, to advocates, others across the spectrum. And for our $16 billion program, think of it as roughly $9 to $10 billion of that is your traditional physical health care. So PCPs, specialists, hospital care, pharmacy, diagnostics, things of that sort. Then we've got about $1 to $2 billion of behavioral health care, and another $5 billion, and the math, some of these overlap a little bit, on long-term care, which is only a fifth of that is actually nursing facility care. 80% of that is care for long-term care for folks in their home and in the community. And that's not traditional medical care at all. It's personal care attendants, assistance with the activities of daily living. One of the things we heard pretty clearly was not only our fee-for-service system has challenges. I think all of you probably experience parts of the medical system and the healthcare system that work well, and parts that are challenging even for a consumer, and all of you, I assume, are relatively well-versed in the healthcare system. I can tell you I am, and when for my family members I have to help them through the healthcare system, I can barely figure out how the heck to navigate it, how to find a psychiatrist for someone, or all those sorts of things. So if it's tough for us, you can only imagine how much more complicated it is for especially if you think of folks on the Medicaid membership, those with serious mental illness, major social determinants of care, all impacting on that. But the other component too is physical health care, behavioral health care, long-term services and supports. Those are all three major components of the Medicaid program. Many of the providers in those three different things, operate completely as silos. So you talk to folks in one area versus another, and you have this great fear, the behavioral health and long-term service and support providers, and I would say maybe I see some health centers around primary care have this great fear parts of the healthcare delivery system in terms of who's got more capital, or do they understand behavioral health care, and providers are pointing fingers at each other, not talking to each other, or half the time, especially long-term services and supports on both sides, you ask healthcare providers, who are the main providers? What are the services of those things? And you ask vice versa, folks do not even know each other. So if you take that sort of system, and then you take our most complex individuals and members in Medicaid, folks costing $100,000, $200,000 per year, sometimes more, who have typically complex medical needs, complex behavioral health, so both mental health and addictions, and then a range of long-term service and supports, each of which individually would be complicated to navigate. You stick that all together with providers that don't know how to work together, don't like each other, don't trust each other, and it's not surprising why we have a healthcare system that doesn't always work. And from a sustainability standpoint, the progress over the past 2 to 3 years we've made to really bend the trend and bring down what was double-digit per year growth down to low single digits. A lot of those things are things we get kind of a one-time benefit from. So we found a lot of things around what we call program integrity, things where we didn't have the appropriate controls either on the eligibility side or on prior authorization of certain services and things of that sort, where we were finding, at times actually fraudulent behavior. We referred 12 types of providers to the Attorney General's office, for example. Those things have yielded between $500 million to $1 billion of annualized savings per year. But what you do on that is you get a one-time kink in the curve by taking out a lot of the inefficiency while still preserving what we have as a very robust Medicaid program. but we're kind of at the bottom of the barrel. There aren't a lot of those low-hanging things where you can go around and find giant, massive inefficiencies that haven't been addressed in the system. And the underlying cost slope, that curve, is still on a particular trajectory. And so from a long-term standpoint, in order to really ensure we're preserving what we're all proud of in the Commonwealth, access in a very robust program, we have the lowest rates of uninsurance in the country. We have to be able to tackle some of these things much more systematically in a structural way. And that's part of why the ACO movement is so important, which we've done a pilot of over the past year, and we're launching in full March 1 of this coming year. I was at a event yesterday with another Medicaid director and a bunch of folks in the healthcare space, and someone asked, all right, people throw buzzwords around like ACO, what does it actually mean? And I think quite simply, without the technical components, we have a system today that, despite the best intentions of individual providers and very committed, very mission-driven people, very capable folks, we're still in a system today that's paying and structured around volume of services. I remember when I was at McKinsey, I used to work with provider systems, and we would do all this work thinking about population health and readmissions prevention, and we'd get down this path where at some point in the fee-for-service model, some of the investments just didn't make sense. Because you pay something that's not compensated for fee-for-service, you reduce volume of hospital admissions and specialist visits and things of that sort, you lose contribution margin. It's like you kind of shoot yourself in the foot from an economic standpoint today in that provider world. And so that's one of the things that does not make sense, and that's part of what moving out of a volume-based system looks like. The other thing, though, that I mentioned to this whole group yesterday is just changing the payment model doesn't solve the world. So it's challenging but not impossible. I think we've done it, to structure a way you can go to a total cost of care population health accountability model. But let's say everyone just magically we started on 3-1 at all, the transition worked perfectly, and everyone's in a total cost of care, population-based, quality-based model. That doesn't actually change what frontline care looks like with individual clinicians and staff on the physical, behavioral health, and long-term service support side looks like to our members. And that's the really challenging work. Many of you in this room are actually on the care provision side. You guys have probably the toughest job ahead of you, which I highly respect and want to thank and commend everyone for, because it is setting up and figuring out how do you respond under a totally different construct for how we think about accountability and payment structures, to do all the things that all of us would say are sensible and we love to do. So 2 anecdotes I'll give you. One is from our pilot ACO program with one of the ACOs that we have. We were giving data to our ACOs for the first time around their actual members. You'd be surprised, it's hard to sometimes give claims data out to folks. So some of these ACOs were seeing total cost of care trend and experience for the first time for their population. One of those, a community health center, took a look at 4 of their most expensive members to see what was going on. 2 of them were in a homeless shelter that served breakfast and dinner, but not lunch. And so they were routinely going, and the homeless shelter is next to a fire station. So they routinely went to the fire station complaining of chest pain, would get taken in an ambulance to the hospital, get a full diagnostic workup, get handed a menu, have lunch there, and go back to the homeless shelter for dinner. I confirmed this both with the community health center independently and someone at the homeless shelter, so it wasn't just the two other individuals were 2 women who during on a monthly basis, because they did not have access to sanitary pads, were showing up in the emergency department to get access to that. If you think of that, I mean, that's almost the easiest example. See, it's nonsensical from every dimension. The health center was joking about the $1,000 lunch that was being provided on that. It's bad for cost. It's bad for member and consumer experience. It's bad for care and quality and outcomes, and it also takes away space and crowded providers for others that need it. So all around, I think there's a way to do this much more sensibly. We also see, and actually Reliant, if you look at, I hope this is okay to call Reliant out in a positive way on this. If you look, Reliant, if you look at the data on Reliant and the total cost of care information, you see very, very positive performance. One of the things you see is if you compare what drives a more efficient performance, you see a much lower use of hospital facility usage and specialist-based care, and a huge spike in office-based primary care. And it's almost, when you plot them on a chart, you see it's a kind of a one-to-one. And that's exactly the sort of thing that you would expect and hope for. More primary care engagement with folks before you're hitting acute care, specialist care, and things of that sort. But it's challenging to get an entire system and to get your frontline practice patterns to be oriented around that. But I commend you guys for having, you know, a long history of thinking in that, together with Fallon and such on that. So, you know, I could go on, and I'm sure all of you have examples of things that do not make sense in the healthcare system, or things when you look at it either from a consumer or caregiver or family standpoint, or from the standpoint of someone in the healthcare system, that we look at it and say, gee, this just does not make sense. We should find a better way to do it. The ACO model is one really important step in that, to fundamentally change the entire payment and accountability structure. It does require real innovation and work at the frontline standpoint, which you know, providers and plans and folks are the ones actually implementing at the end of the day. So that is our hope and our strong push, which is we're setting up this thing, and you know, it's a 5-year waiver we have with the federal government. There's $1.8 billion of federal funding that we've negotiated to come in to really help on a transition of this sort, because I think we recognize that you don't flip the healthcare system overnight. You don't find savings overnight without some investment, and we made the pitch to the feds that we were going to put a very exciting, forward-thinking model on. We were going to move our whole system into this, and we needed some co-investment from the feds in making this happen. So that's all kind of context on why we are where we are. Starting March 1, I think we will be in the most significant shift of the structure of the MassHealth program since the mid-90s. We will have 80% of our lives where we are the primary payer. You know, we're not wrapping coverage for someone on commercial coverage or something. 80 to 85% of our lives will be in one of these 17 ACOs that we have. Most of those ACOs are a joint venture together with a health plan, where we're providing a full capitation, risk adjusted to that ACO, and a handful of them are in other sorts of arrangements that also have material total cost of care accountability. And we're in the midst, we started mailing out before Thanksgiving, 1.3 million members we have getting letters around where what the ACO options for them in that given region are, where their primary care is moving to, etc. So that major transition is on. It's a very, very, it's a thing we're monitoring on a day-to-day basis. When you send 1.3 million letters out and tell people about a new care delivery model, you start to get phone calls of folks asking, what is this ACO thing? What does this mean for me? Where's my primary care? Etc. So that's all happening. I'm sure it will go fantastically smoothly. So the final thing I want to mention before just opening up for thoughts and comments and questions from folks is the other component of what we have been implementing throughout this whole process is in our federal waiver is on opioids and addictions. So we received authority through our federal 1115 waiver. This is a big priority for the governor and for Secretary Sutters to really attack the opioid crisis. So we are expanding the full MassHealth benefit to include the entire continuum of addiction services. If you think of what happens today, we spottily cover various parts of addiction services, primarily in acute settings. And then depending on what Medicaid product you're in, some folks might get some diversionary step down, but we don't cover residential recovery and the entire continuum. What we see is folks are consistently starting to make it down from acute detox and things of that sort. The benefit ends, and people start to cycle back through the system. So what we are in the midst of implementing, it's $150 million over the course of 5 years. The full spectrum of addiction services through residential recovery will be fully included in the MassHealth benefit, no matter what part of MassHealth you're in. We expect to be on track over 3 years to be expanding capacity by about 500 new residential treatment beds. There's a lot of work on other supports for addictions, and that's a very important part of the waiver that links into this thing called behavioral health community partners. All these things kind of fit in. I won't talk too much about that right now, but I did want to make a note of that because for ACOs, if you look at some of the most complex, high-cost individuals, there's a high intersection there between acute medical need, mental health, and the addictions component as well. So with that, let me just pause, and I'm curious what questions or thoughts folks have this morning. I'm sure you're all wildly supportive.
Hi Dan, Ken Bates, the CEO of the Bridge of Central Mass, and we are signing our contract as a behavioral health and LTSS community partner. Thank you, we think. We'll see how it goes. Thank you for referencing the 4 individuals that you were talking about in terms of the high cost. I'm curious about the social determinants funding and how you envision that getting to maybe the fire department could get some of the funding to pay some of the lunches there, but how is that connection going to be made for those things that people need in the community when primary care is, pretty much in their offices, working on care plans? How do you envision that connection happening?
You should ask Tony and Fran right next to you.
We're trying to figure it out.
So there are 2 components, funding and understanding the needs of individuals. I'll start with the second piece first, because if you do a Venn diagram between the 2 to 3% most complex, highest cost individuals, there's an extremely high overlap for that population, and as I mentioned, let's just take on the behavioral health side, folks with serious mental illness, addictions, and very often significant health-related social needs, housing instability, food instability, and a whole bunch of other things. And those are the folks that are coming in and out of the emergency department and other things as well. So one of the things that we have done in the ACO structure is, and actually when the secretary and I were going around doing all those listening sessions, what we heard time and time again is you get, and we have many great healthcare providers sitting around the room today. I would say both from a member and family standpoint and from a provider standpoint, folks generally say, well, I'm really afraid whether or not the ACOs, the traditional healthcare system, really fully understand or have worked with across the continuum, not just on the medical side, but on the social service side and on behavioral health care, the needs for that population, where you're really getting far beyond traditional medical care and engaging folks with peer supports, recovery, all of that far outside of the 4 walls of any traditional medical setting. And folks were generally pretty afraid that if we just went ahead with an ACO model, some ACOs would have more or less cultural sensitivity, expertise around that. So we developed this thing called the Behavioral Health Community Partner, which I'm referencing, where we procured for that a set of entities who have community-based expertise, not only on complex behavioral health conditions, but also into some of the social services and things of that sort. So one of the requirements that we make very clear in the ACO contracts is that for the highest, most complex individuals that fit into that category, the ACO must be working with a community entity like a behavioral health community partner to really ensure that the holistic set of needs are identified, not just on the clinical components for your medical care, but a whole range of health-related social needs. That's step 1. Half the time we find people don't even understand the full set of those needs. Like those 4 individuals I mentioned, until folks in that pilot ACO started looking at the data, folks did not have a conception of what was actually happening there. On the funding component of it, there are 2 things there. One is for ACOs, especially the majority of those in what we call a Model A, receiving a full capitation. The beauty of the capitation is there's a lot of flexibility underneath that. When we're not in a capitated model, every single service that we pay for in the Medicaid program, we have to basically get authorization from CMS for it. The fee schedule, what it is, we have to claim for it, we get audited to make sure none of those claims are for things that shouldn't have it. That doesn't give a lot of flexibility when it comes to the social services and things of that sort. In a capitated model, especially for some of the high-cost individuals that are $200,000 per year, there's quite a room to be creative under a capitation where we don't need to rely on federal authority for every single thing that you guys spend on that. So that's one important flexibility. The second is part of district. There's some flexible service funding in that as well. I didn't mean to go on and on just to that question, but I didn't touch on this earlier, and it's a really important part of what the Secretary and we are focused on in the restructuring process. No other questions? Eric?
I think Anthony's got me mic'd, so. I'll turn both on. So we're seeing at UMass Memorial a significant shift from commercial insurance into the Medicaid program, and that drives your costs up significantly. It also has a negative effect on us in terms of we're seeing a profitable book of business move to an unprofitable book of business. Do you have an understanding of why that's happening in Massachusetts, and what should we expect that to continue? Are there things that we can do to reduce that over time?
It's a very good and timely question. For those of you that follow the state budget process, you'll probably recall that this past year the governor did introduce in his proposed budget a set of MassHealth reforms to address exactly what Eric just mentioned. So what we have seen, and this is not the fault of any individual, it's just the way the system has been set up. Over the past several years, we've had a significant migration of the percentage of lives in Massachusetts covered under commercial insurance onto MassHealth. So our caseload has increased substantially. What that's done is we fully acknowledge commercial pays the highest, then Medicare, and then Medicaid. That shift of probably 400, 500,000 lives over the past 5 years put significant fiscal pressure on providers, right? You're switching from a higher reimbursement book to a much lower reimbursement book. It then puts double pressure on because we as the state, within our budget, are trying to figure out how to maintain access, eligibility, and absorb 400,000 to 500,000 new folks covered. That certainly has us in you're not seeing a lot of rate increases. I think we would all acknowledge that. So it puts extra pressure on the system there. So the governor had proposed in his budget this past year a set of reforms that would help to alleviate some of those things. That is in live discussion with the legislature as we speak. There's a question here.
Bob Quinlan, a retired surgeon and a caregiver, and I'm wondering about these three foundations of physical care, mental, behavioral problems, and then long-term care. How have you managed in your pilot the communication effort between the providers? Is there something special about whether you're using information technology or whether you have more manpower to convey how to treat these complex diseases? Is it done in a standardized way, and does that help costs?
So is your question about how are providers communicating with each other?
In your ACO, have you set up anything special as far as?
So yeah, yes, for the model going forward. The pilot, there's only so many things we could do with the pilot, but part of what we're looking for in the ACO and the behavioral health community partner model is integration across the provider continuum. So within the physical healthcare side, between primary care and specialists, et cetera, I don't necessarily mean organizations owning each other, becoming one, but becoming much more clinically integrated. And the same is true for the ACO and health systems and the behavioral health providers. So one of the contingencies on receiving the new federal DSRIP, the $1.8 billion, is the ACOs need to be working and partnering with those behavioral health community partners. They need to have a memorandum of understanding of how the care delivery engagement, how the care team works, how the data gets exchanged, who is on point for taking first for those things, and that's a requirement for us to see before the funding flows out. We're not going to try and prescribe how every one of you needs to engage on a day-to-day basis. We need to know that there is a clear plan and structure and a partnership that's developed on that. We need to see that documented, and then the funding starts to flow from that. Thanks. Question there?
Thank you. My name is Jackie Litwell. I work at Athena Health. I know we're here to talk about cost of care, but I'm really also interested in how these ACOs are also going to be looked at from a quality of care perspective. How are these patient outcomes going to be measured and reviewed and adjusted as the model evolves?
It's a good question. We could spend hours on that, so I'll be brief and then we can go offline on some stuff. I would say there's a set of very clear goals that we're trying to achieve and measure in the ACO program. Some of those things are things we can hold folks accountable for, part of the payment model, based on quality metrics where they're precise enough that you can measure someone, compare them, and hold payment to that. There's a whole work group on that. There's like 26 different quality measures and things of that sort. But we know on a lot of these things, quality measures only go so far, at least those that are validated by a national entity, are comparable, are reliable, are statistically valid. So there are quite a number of other things related to the sort of things I was talking about earlier, where they are more of a contract management measurement. We want to see what's happening with the ACOs. We're going to track the data, even if sometimes it's not exactly statistically reliable to the precision that you otherwise would love it to be. And we'll hold folks accountable on that. So it's both quality measurement in the payment model as well as day-to-day contract management. So maybe one or two last. Tony, you look like you're about to say something.
Because I never can be quiet. So there's a group of community health centers that have formed a community health center centric ACO, and one of our I guess the best part of what we're doing together is that we really are all like-minded individuals doing like-minded work. We're having to negotiate, obviously, in a very statewide way. I would say one of our challenges is going to be around behavioral health because there's so many partners statewide. And so I think I'd like your advice on what might that behavioral health model look like in a statewide kind of way versus community by community, because that really does make a big difference when you're talking about 15 community health centers working together.
Right. So it's always that's a full discussion we should have, otherwise we'll offline, otherwise we'll spend 2 hours talking about this. The tension we're always trying to balance is making sure that we are doing everything we can from a policy and programmatic standpoint to push for the type of clinical integration that we're looking for across, say, physical and behavioral health, without trying to get overly prescriptive of the day-to-day care delivery practices, which if we try to get a little bit too prescriptive, maybe we'll get it right for 20% of the providers, and for the other 80%, we'll probably force folks to trip over things even more. So on that, I think, Tony, you're asking specifically about the ACO relationships with the several different behavioral health community partners across the state. I think we'd love to see as much consistency, scale on how ACOs and community partners are working together as possible. I was just with an ACO the other day already thinking about with their behavioral health community partners, how do you stratify the population? When you have a primary care case manager plus a behavior, who is doing what day to day when folks are sitting around the table? Who is the individual that actually follows up with the member versus is participating on the care team? Those are exactly the right questions to ask. To the extent that folks are doing this discussion 15 times over, it's great in my mind to get scale and consistency because we're trying to build a system here, while we recognize there are unique variations that need to occur by geography. So that's a non-answer to your question, Tony, but let's talk about that more later too. Maybe I'm conscious of the agenda time. Maybe one last question, and then
Dan,
Tom?
you've mentioned disrupt a lot. I don't know if everybody really, you've mentioned disrupt a lot. I don't know if everybody in the audience really knows what delivery system reform incentive payment actually means,
So that's a cue for me to explain that.
Yes.
Okay. Because we could talk in acronyms all day long on the Medicaid program. So DSRIP, it's a federal term, but it's a federal term in a vehicle we used when we negotiated this whole waiver, which gave us the federal authority to restructure our Medicaid program in this way to generate and receive $1.8 billion of funding over the course of 5 years to invest into the system around ACOs, around community partners, around the social determinants of health, etc. And that negotiation was a year-long negotiation that concluded on November 4th of last year. And we had basically, in the Commonwealth, about $1 billion of funding that was set to expire through our previous waiver. And the gist from the feds, which we didn't disagree with, was you got $1 billion of this funding going around supposedly on delivery system reform. Where is the delivery system reform? So we said, you know what? We agree with you on that. That $1 billion is actually for critical funding for the safety net. Let's call it what it is, move it into structures, make it quite transparent to people what that is. And feds, we have a very exciting approach of really moving across the system to value-based ACO payment structures. That will not happen overnight, and that will not happen without investment. So co-invest with us in this, give us $1.8 billion, and that's basically what it is. It follows individual ACOs based on their primary care volume. That's about 2/3 of the $1.8 billion. The other third goes to the community partner entities and to a range of the flexible service dollars that ACOs can use on things that traditionally Medicaid has not covered quite as much. Okay, well, I know there's a lot of other stuff coming up, so I should turn it. Thank you all for what you do, and we're looking forward to working together across the entire healthcare continuum as we roll this out. Thank you.
Dan, that was terrific. Thank you so much. Dan is in like 3 places at once this morning and has another speaking engagement where he'll eat his 3rd breakfast.
A lot of coffee.
And a lot of coffee, right, exactly. So thank you so much for joining us. Great opening to the conversation this morning. And what I'm going to do is give you an abbreviated introduction to our moderator and to our panelists. When I say abbreviated, you won't like it if I read their full bios, which are in the program. You can read them yourself unless you forgot your reading glasses. They're in about 8-point type. So it's a challenge if you don't have those. So let me bring the folks up. By the way, does it matter who sits in what chair? It does? Oh, they know. Oh, perfect. Okay. So I'm just going to read this order. Or actually, why don't they all come up and I'll just tell you who everyone is, if I may. Our moderator, who asked that last question, Dr. Thomas Ebert, is Executive VP and Chief Medical Officer at Fallon Health. Dr. Ebert is responsible for ensuring the appropriateness of quality and cost effectiveness on the healthcare services received by all Fallon members. Prior to joining Fallon, he served as Chief Medical Officer at Health New England, a subsidiary of Bay State Health in Springfield. Dr. Ebert has a strong Worcester roots as he practiced nephrology for over 20 years at Memorial Hospital, and was also a longtime professor of medicine at UMass Med. Dr. Eric Dickson, sitting next to him, is the president and CEO of UMass Memorial Healthcare, the largest non-for-profit healthcare system in Central Mass, if you didn't know that, with $2.3 billion in annual revenues, 1,700 physicians, and more than 12,000 employees. Sorry. UMass Memorial's 3-hospital healthcare system has over 1,000 licensed beds and includes 1,100 physicians in the UMass Memorial Medical Group. He still teaches emergency medicine at UMass Medical School and has done lots of other impressive stuff, including lecturing nationally on the use of the Toyota production system in healthcare, which is working with health systems around the world to reduce costs while improving quality. Next to him, Jonathan Chines, the Vice President of Payer Contracting and Networking Strategy at Reliant Medical Group. Jonathan's new there as of what, 7 months ago we said? 6 months, okay. And he's responsible, responsibilities include the strategy, negotiation, and management of Reliant's relationships with commercial payers, and for leading Reliant's accountable care organization initiatives with Medicare and the Mass Medicaid program. He was previously for 11 years with Tufts Health Plan in a variety of roles, and also worked at the Philip Johnson Associates, a Boston-based health and human services consulting firm, and the Mass Executive Office of Elder Affairs. And next to Jonathan, Lisa Whittemore, and Lisa is a principal in the Boston office of Health Management Associates. Lisa's work focuses on strategic planning, practice transformation, behavioral health integration, alternative payment models, and delivery system reform. Prior to joining HMA, Lisa was a VP of Network Performance Improvement at Blue Cross Blue Shield of Massachusetts, and has held leadership roles in community health and mental health centers, community hospitals, academic medical centers, as well as agencies on aging. So we won't be going till 5 p.m. We'll be going till around 10 or 10:15. But I think Dan really kicked off a lot of good things that we can begin to talk about. And we have the great benefit of our moderator also being a fourth expert. So Tom, it's yours to kick off. Thank you.
So a lot to talk about, and I think Secretary Tsai really teed up some questions that we'll explore that really are related to the issue that the state is addressing in terms of trying to manage costs for such a large population. But why don't we start with some things that I think hopefully are working. We've all been addressing cost of care and the rising cost of care for a long time. I thought maybe we'd start with some programs that you've seen some success, you know, that you've tried in your institutions and seen some success, and perhaps for Lisa, you as a consultant, some things that you've seen out there that really seem to have traction and are real opportunities. And for Dr. Dickson, you know, perhaps bringing in a little bit of the work that you've done on lean to try to improve healthcare. So why don't I start with Eric as something that's working.
Thanks, Tom. So let me just start by saying thank you for the opportunity to be here with Peter and Tom and with my colleagues on the podium. I want to first agree with something Dan said. We absolutely, positively have to bring the cost of healthcare down. In the Commonwealth, in the United States, it is squeezing out everything else we want to do. Right? Infrastructure, K through 12 education, any program that you would like to be sponsored by the state, healthcare is taking a larger portion of the state revenue and therefore squeezing everything else out. That's happening at the state level, that's happening at the national level, and it's getting worse over time, not better over time. In the commercial space, and we're seeing the same thing happen. Companies in the United States, companies in Massachusetts, not able to compete because of the cost of healthcare. For our own healthcare system, we spend $150 million on healthcare for our employees. We spend less than that on the pharmaceuticals and implantable devices of our patients. We spend more on healthcare for our employees than we do on the medications that we use to make our patients better. And that has a profound impact on us. So we have to do something, and that's, I think that's important to say up front. So what have we tried that's worked? And I can also talk about what we've tried and it hasn't worked. So bundle payments work. You know, if you look at what we've been able to do through bundle payments in coronary artery bypass grafting, total joint replacement, spinal surgery, through early teaching to patients undergoing those procedures, with care coordination throughout the 30 days in and around the time that the patients have those procedures. We've been able to save the federal government millions of dollars in cost of care, while at the same time generating a surplus to help support the infrastructure investments that we've made. Especially because Fallon's here, what we're doing in the Navicare program works. We have embedded navigators in our primary care practices to work with patients that are covered under Navicare as their insurance option, and our primary care doctors love it. None of the pre-authorizations for medications or specialty consults, the navigators take care of all of that. Works for us, works for the providers. And so that's what's works, and I'll maybe turn it over to my colleagues and then
we'll talk a little bit about some things that doesn't work. Sure. Jonathan?
Sure. So, at Reliant, I think we're a little bit unique in the world of healthcare, where the delivery system reforms that Secretary Tsai talked about are things that we've been working on for 30, 40 plus years. And so as we think about what works, that model of accountable care, that model of population health management is what's worked for our organization. We have, as a consequence of taking global risk for our Medicare, actually a number of our Medicaid lives historically, as well as our commercial lives, we have had to build a robust population health management infrastructure that includes care managers embedded in our sites, includes investments in data and analytics to make sure that we know what we're talking about, what we're trying to manage. We're also embarking on an effort right now led by Dr. Thad Schilling, who's here today, to transform the way that we provide primary care into a truly team-based model. And these are the things that we think will work. The challenge for us, and I know we'll get to this in the discussion today, is making sure that the way the payments are set up are aligned with a model in that way. We've had a lot of success in our organization in doing that. There's still a lot more opportunity, and I think one of our challenges is to figure out how do we sustain this infrastructure, this care management model that is successful in an environment where the payments are still varied across the spectrum.
Lisa.
So I've had the opportunity in the last 2 years of being able to go around the country and see a lot of different stuff. And I would agree with what Eric said, that bundled payments do work. I also would agree that for some systems, like what Jonathan is talking about, if you're a closed system or a owned system, it works because you have the flexibility, you can negotiate a capitation. It becomes much more challenging if you're a more porous system where you've got different types of providers. Some are employed by a hospital, some are private practice. That becomes a much more challenging environment to make this work. I've seen a lot of behavioral health primary care integration work if the funding can follow it. The new codes for the collaborative care model I think are very promising because they actually pay for that kind of care. But what really works is flexibility in design, and I think that's when Dan Tsai talked about delivery system reform, incentive payment, we have to be more flexible and move away from this. I provide a set of services and I get paid only for those set of services, and thinking about whole person care. It's much easier to do in an environment like a Reliant than it is, for example, I ran primary care at Brigham and Women's Hospital in a Partners, which is a very porous and expensive system.
So there are some things that do work, and if we didn't have these kinds of programs, it would be even more difficult to talk about controlling medical costs. On the other hand, we know there's some things that haven't necessarily panned out, and I think Eric was going to maybe start with something that didn't work the way you expected it to.
Well, and I think that, I can give two examples. We have a Medicare Shared Savings ACO. It is a program where if we are able to reduce the cost of care over time versus projected, we would get a surplus payment, which aligns us hopefully in care coordination and things like that. If you look across the country at those ACOs, about 1 out of 20 actually has a surplus after they take into account the infrastructure costs that they've invested in. So if you have a program...
And the 2% that the government takes.
It's worked for the government because they don't put any of the infrastructure costs up front. And it's worked for some of the less porous, I think that's the perfect term, healthcare systems, and I think it's worked for the patients. We've seen in most ACOs quality go up, and the coordination of care for the highest utilizers of care improve. And in our own ACO, led by John Greenwood, who's in the room today, I mean, I know that we have patients that are getting better care because of the ACO, but it's costing us $3 million a year to do that, with little hope of ever getting that back year over year in those investments. So, you know, the global ACO model for some systems, I think will work. Those are going to be the tightly closed systems. For a porous tertiary referral center that fills most of its hospital beds through emergency cases that are transferred well outside of its primary care base, it's a very tough model to make work.
Jonathan, Reliant's been around and doing really extraordinary things with, you know, through global budgets and so on, and the kinds of investments. But what hasn't worked? And you know, maybe this is an opportunity for you to talk a little bit about how Reliant has 300,000+ patients, but the global payment is really only for about a quarter of that. And how has that actually impacted you know, how Reliant works?
Yeah, so I think a couple of things. First, I do want to sort of tie back to something that Eric said around some of the ACO models. As you think about these ACO structures, the structure of it also matters. So we're currently in an MSSP ACO, we've been in Pioneer. One of the things that we've found over the years is that the particular rules and complexities of each ACO model affect your performance much more than you realize. You think it's simple, you take global risk, you perform, and you do well. It's actually much more complicated than that, and there are ways, I think unfortunately, in the way that some of these structures are set up, where your performance can vary based on things that really aren't tied to clinical efficiency or quality. And so I think one of the frustrations we have, and one of the challenges that we have, is that when you think about a global risk arrangement, if it is not structured in the right way, the incentives can still be perverse and can still sort of work in an opposite direction than you would expect. And I'm sure that both of our organizations have had that experience in some of these arrangements as well. You know, you alluded to the fact that when you look at our organization, we've got about 300,000 patients, about a third of whom are in a global risk arrangement. 2/3 are not. And so, you know, you see this expression around having sort of, you know, feet in different canoes. We're very much living that.
I think this is Dr. Dickson's famous line.
That's right.
Actually, so we'll give credit to...
That's right. So, you know, I think for us, it's when you think about how you run your organization, to succeed in value-based care, there's so much that you need to do right. It's infrastructure. It's also culture. It's also, you know, how do your physicians and all of your providers across the organization, all of your staff practice, how do they work together to manage the health of a population and not just focus on that one episode that's right in front of them? It's an enormous, I mean, to bring in a consulting term, it's an enormous change management challenge for any organization, whether you're an integrated employed organization or a more diffuse organization. And so one of the things that we've sort of realized is we can't try to operate in both. You really do need to kind of set your strategy and figure out which direction you're going to go. And for us, that's meant going into value-based care. So we've got a third of our patients in value-based care, 2/3 that are fee-for-service. The vast majority of our revenue, and quite frankly, the vast majority of our margin comes from those patients in value-based care because that's how we've set up our system. For us to survive and thrive going forward, based on the strategy we've selected, we really need to figure out ways to get more of our patients in value-based care because fee-for-service just doesn't work the way that our organization is set up. And you know, for us to try to make fee-for-service work, we'd have to sacrifice some of the things that we're doing for the populations that we have risk. So, you know, we've had to make a choice. I'd say we're fortunate in that, you know, I think we've kind of passed that tipping point where this is a choice that makes sense for our organization from a survival standpoint. But you know, you don't get there overnight. You know, you really have to work to get there, and I think that's been one of the challenges that we've faced.
Lisa, you've seen the transformation of healthcare around the United States, and some places more successfully than others. What what kinds of things are really needed particularly in an integrated system to really move the needle and really change sort of how people think about care and managing a population?
Yeah, I think there's a lot, and I got into this when I was at the Brigham and doing primary care, and we couldn't recruit providers because nobody wanted to do primary care. It was not a sustainable life for a provider, so how can you think about doing things differently? And what Massachusetts has done, what Assistant Secretary Tsai was talking about, is they've embarked on this incredibly ambitious transformation to accountable care organizations across 80 to 85% of the Medicaid lives. Nobody else has done that. What they've done that I think will make it work, it's clear attribution. Primary care providers can only be in one model. There's a lot of controversy about that in the beginning. New York State said, I actually worked with a community health center in New York State that was affiliated with 6 of what they called PPS, provider performing systems.
Which were thrown together, by the way.
Which were thrown together, cobbled together. Yeah. And they also were driven by large academic medical centers and hospitals. They weren't primary care driven. And I think that's a really critical factor for success, that you have the accountability with the ownership of the lives. So it really elevates that relationship between primary care. I think the other really important factor here that I'm not sure anybody's really done very well is how do we engage, I don't care if you call it patient, client, member, the consumer in the process of this. It's sort of been behind the scenes contract negotiation, either with the feds, with the state, or with the commercial payers, and what am I going to have the quality for? But nobody's really said to the member, by the way, and I worked at Blue Cross Blue Shield, you're in the alternative quality contract. And the complaint that we heard from the providers in the alternative quality contract was, wait a minute, you're not supporting us to help manage the care because the member benefit wasn't necessarily tied in the same way to the provider contract. And I think we have to make it much more transparent for it to really work and to engage the patient more. And the last thing I want to say is around community health centers. I think it's really important that we think about the other services that community health centers offer in addition to medical services. Those are going to be critical, particularly in the Medicaid ACO space. And I think we have a lot to learn from those services. And you talked about Navicare, I think community health workers, but really negotiating those non-medically driven social determinants of care, but psychosocial stressors. I mean, I am a social worker, so.
You heard in the introduction that I'm a nephrologist, and one of the things that I remember is that with a stroke of a pen, I ordered a lot of stuff, but I didn't necessarily know that I'd order a lot of stuff. And I think that what Secretary Tsai was trying to get across is that there are a lot of services that physicians are responsible for, but don't necessarily know that they're responsible for. So maybe we could explore a little bit, for example, long-term services and supports, and particularly in the things around behavioral health, and perhaps talk a little bit about how you try to sort of train your charges, because you've got a lot of residents who are learning that actually people follow their orders, that you actually write something and something happens, but you may not. But do they actually understand the implications of that? And we sort of go down the line and talk about that a little bit.
Yeah, I think that you can spend a lot of money with the stroke of your pen, getting a test that you don't need, or ordering a drug that's more expensive than it has to be, or a consult that you really shouldn't have got. And one of the reasons that especially residents and early career physicians do that is the fear of getting sued if they miss something. And I think one of the reforms that we need to talk a lot more about is malpractice reform. If you look at physicians in the United States, our probability of being sued during the course of our career is 3 and 4 times that of the rest of the world. And that has a profound impact on the way we deliver care. Now, unfortunately, the studies of malpractice reform suggests that it takes a very long time to change that, maybe a generation, right? Because once you've learned it and you've started practicing in a certain way, just because somebody passes a law and tells you, don't worry, you can't get sued as much anymore, it doesn't change the way you practice. So part of that is embedded in you as you come through the residency process, the training process. What we have tried to do to both protect our physicians from inappropriate suits and improve the quality of care and manage the cost of care for our patients is to try to standardize care in a gold standard way and teach them that gold standard. So one of the things that gets you in trouble is the great variability that exists between providers when they deliver care. Because of that variability, you get sued and somebody say, no, I wouldn't have treated it that way. And I'll give you an example. As an emergency physician, we order x-rays for patients that are in car accidents, and more increasingly CAT scans, to look for a cervical spine fracture. We all had different rules of the way that we would do that until a study called Nexus came out that taught us exactly what the gold standard way for when patients needed it, when patients didn't. And then we started to teach our residents to apply those rules. We were able to significantly reduce the number of x-rays and protect our physicians from suits, because if they follow the gold standard, the standard of practice, they're much less likely to get sued. And so if you define a standard way and a physician follows it, and you define that standard in a way that's economical and delivers high quality care, you actually can reduce all of those things. So our main theme right now is standardization is the adoption of excellence, and it's not the loss of autonomy, and that's how we're teaching our residents, and that's how we're trying to practice medicine.
Jonathan, I know that both UMass and Reliant have captive insurance companies, so how has that actually helped, having a captive to really kind of push providers into adopting standards as Eric was talking about?
It has, and this is not my area of expertise, certainly as sort of a new person in the organization, but the sense that I have is that having a captive and having the flexibility that captive gives us to sort of look at medical malpractice in a different way and look at the way we address potential errors or potential sort of patient issues in a way that's intended to be more productive and less sort of litigious, I think has helped. I do want to sort of agree wholeheartedly with Eric's other comments around standardization, and I think that's something else that's been very important to our work, both from an education standpoint, but also having a technology to support that. So in our EMR, for example, all of these sort of best practices and care pathways that Eric's talked about, we've tried to program those in. So not only does it make it easier for the provider to figure out what's next and sort of make the right order, but that right order is already sort of pre-populated. So if you're doing something that's outside of that standard path, it actually takes more work for the provider. The final thing that I do want to sort of make the point in this area is, for us as a physician, basically a physician-only organization, we rely on care happening in a lot of different partner organizations, whether it's UMass, St. Vincent's, anyone else in the community. And so the final thing that I think is important for us is, as we think about the standard of care for our population, how do we work with our partners to make sure that standard of care is applied when a patient goes outside of the four walls of Reliant? And so I spend a lot of time focusing on working with our partner providers to make sure that the way that we want our patients to be treated is followed consistently throughout the ecosystem, whether, again, it's at UMass, St. V's, or anywhere else, so that if we have an expectation for how our patients will be treated in Reliant, that follows through outside of our system as well. And I think that's one of the challenges and one of the opportunities with the ACOs that Secretary Tsai mentioned is all of us that are in these ACO models will need to be kind of doubling down on that strategy of figuring out how do you work with your partners to come up with a common understanding of how you want your patients to be cared for, and how do you work with your partners to make sure that communication happens back and forth so that you are doing the right thing for your patients.
Lisa, anything to add to
The
that?
only thing I want to add to that is to think about the care team. I think so much has been on the back of the individual provider for so many years. Yeah. We really need to think more about expanding the care team and having, you know, that trite phrase, the right person doing the right thing at the right place at the right time. And there's so much more that we can leverage from medical assistants, from nurses, from social workers, in particularly the primary care setting. To do that, it's going to be very important to succeed in a population health management model, because if we ask the provider to do everything that needs to be done, we'll lose all the providers. And the HIT, or the Health Information Technology, the Health Information Exchange, is going to be crucial for success in an accountable care organization, because you need to know where your person is, wherever they are in the system, and there's a lot of work that I think needs to be done in that.
I do want to sort of just reinforce and agree wholeheartedly with the point on sort of finding the right people to care for folks, developing a care team so it's not just the physician that's doing the work. You know, again, as a primary care focused organization, you know, one of our realizations is that it's much harder to recruit primary care physicians than it ever has been before. And if you're not mindful of the burden of work on primary care physicians, the job, quite frankly, can be very hard and not particularly rewarding. And so, you know, for any of us to be successful and for any of our organizations to make sure that patients are getting the right care, you know, we really have to focus on transforming that model of care and making sure that we do so in such a way where everyone's practicing at the top of their license, and you're not having primary care physicians who are highly trained, quite frankly, expensive resources working on things that someone else can do. That's been a huge goal of ours over the next several years. That's part and parcel of that care transformation effort that I mentioned earlier, and part and parcel of also how we expect to succeed in things like the ACOs in the future.
So I want to turn to addressing the challenge that the state has undertaken in terms of moving probably 2/3 or even up, as Dan said, 80% of those receiving Medicaid benefits into these ACOs. And I think that when he spelled out the $16 billion, I think that this is a number that I think a lot of people don't understand, which is that it's $9 or $10 billion for medical services, a huge amount. But $1 to $2 billion for behavioral health services, and we're going to address that, and I'm glad Lisa's here because this is an area of expertise. And then another around $4 or $5 billion for long-term services and supports. And I think many of us have always thought that was going for people in nursing, long-term care in nursing homes. But in fact, a lot of it is not going for that. And I think that the challenge that the state has is how do they actually manage and rein in that expense? And I wanted Secretary Tsai to explain DSRIP because we'll talk a little bit about it. But let me start with two decisions. One, we may have had 2 ACOs in Worcester, but we actually have 1. And Reliant has decided to go forward with what's called a Model A. And UMass, after much effort and participating in the pilot, had decided not to, at least in the first round. And I thought we should at least talk a little bit about kind of those decisions. And so let me start with you, Eric, just because I think that UMass's decision did have a big impact on sort of how the state, what the state needed to do, because UMass is such an important institution in the state.
Yeah. I first just want to acknowledge there are 3 ACOs, and certainly the FQHCs participating with CCC.
Right, because
they had hoped to participate with us.
They're across the state, that's true, yes.
But, and really they have a lot of covered lives and doing important work. And I think also Steward with CMIPA
I guess does touch into ours.
Much smaller than the other 2. So
that was a Worcester-centric kind of statement that I made. So,
But it's always dangerous to correct the moderator because you can get me back afterwards. So,
I stand corrected.
So I described our experience with our Medicare ACO, a $3 million a year investment, better care for our patients, quality increasing, better coordination for high utilizers of care, financial loss. That makes it a mission-oriented activity. You know, we do a lot of mission-oriented things. We do a lot of things that lose money but are good for patients. We're not for profit. That's just part of who we are, our fabric. And the ACOs in general, for us, we believe are good for patients, but typically don't work out financially. And so you have to take a very close look at that. And when we looked at the ACO that we had built, and we had this dream of a grand overarching ACO in central Massachusetts with 100,000 plus lives, and what the potential downside in a really, what I felt was an inflexible program that was an 11% risk corridor for us, and what the reserve would have to be in order to put cash away for the potential downside. It was definitely a mission-oriented activity. And in a year that we went live with our new IT system and had almost nothing for a margin, we just couldn't take on the additional risk. And so it's something we really wanted to do. It's something that we hope to do in the future. Maybe we'll get in 19 when things are a little bit through our IT go live and a little less spending there. We anticipate that we would likely take financial loss if we do participate in any of the models that have been presented. But we're willing to do that because I think it will result in better coordination of care for our patients and higher quality care. It's just not something that we didn't have the money to do that. We would have had to cut lots of other programs that we think are equally important. But we participate in all the pilot ACO programs up until this point. And so for the first 9 months at least, it looks like we'll be out and remain optimistic that we'll come in later program. And I should mention, we are participating in the ACO through Community Health Link, UMass Memorial Community Health Link. They are a community partner, and they will be working very heavily in the behavioral health space with the other ACOs to provide those services. So not in the full risk arrangement, but in the community partner section we are participating.
Jonathan, Reliant made a different decision. Talk a little bit about that.
Sure. So, first of all, our circumstances are obviously very different than UMass, and as an organization that is on a single medical record, we appreciate and understand the investment that it takes to get there. And so, I think we're at a different phase in our history. But if you go back to some of the comments that I made earlier around our philosophy and what's worked well, for us, being in value-based care not only has worked well, but it is sort of the existential way in which we're going to continue to survive and thrive in central Massachusetts. And so as we look at the basic structure of what the state is trying to do with MassHealth restructuring, it is very closely aligned with our philosophy. It's also very closely aligned with how we've historically worked with Fallon in Medicaid for the last 20 or 30 years. So we have taken risk for the Medicaid population with one of the payers that we work with. And so to some extent, this is sort of an extension of that relationship that we've always had. With that being said, there is a lot of risk involved in moving forward. Certainly there's the downside financial risk for any of the organizations which we're all taking on. There is the risk that involves in taking really an enormous population across the state and transitioning these folks, folks that, do have a lot of disadvantages when it comes to their ability to navigate the system, transitioning 1.8, 1.9 million people into new model. There's a lot of risk there for the state and also for organizations like ours that are caring for those patients and want to make sure we do the right thing. So we're mindful of that. We're also mindful of the fact that as we think about some of the rules of the program, there are nuances to the way that budgets are set and so forth that cut different ways for different organizations. For us, as we think about being in the ACO in 2018, because of how the budgets are set up and the state's need to ultimately reduce funding, we do expect that we'll take a hit in our budget relative to where we are in 2017. I think that hit is temporary, and I think that's something that we'll be able to manage our way out of by continuing to provide high-quality care to patients, to the folks that we're serving, and to enhancing that. But certainly there was a lot of risk there. We were mindful of all of that, but again, at the end of the day, as we looked at the structure that MassHealth was setting up, we said, this is ultimately where we want to be. This is a development in how the state is running Medicaid that we want to be able to support and be part of, and that's why we made the decision to participate.
Lisa, you're a bit of an outsider in this, in a way.
I didn't have to make a decision.
You didn't have to make a decision, but obviously you're an observer and an expert. Where are the pitfalls, and where do you see sort of opportunity for it?
So my biggest worry is the MassHealth or Medicaid population is a different population than the Medicare, or even the commercial population.
Say a little bit more about that.
So if you look at what has worked, particularly in the Medicare, the shared savings programs or the pioneer ACOs, it's a very highly intensive medical model where you provide in-home support services, a lot of high-intensity nursing care management. The population in MassHealth has a different piece of need, a different type of need. If you look at the entire MassHealth population, a lot of them are in the category called TANF, which is temporary assistance to needy families, or temporary aid, I forget. But these are people who struggle every day to get to work, are underemployed, have psychosocial stresses, a lot more addictions than you see in the Medicare population. And the programs that we've set up in facilities mostly are nurse-led care management programs. And so I worry that relying on that model for this population is going to be higher cost and less effective than potentially a model that looks more at social determinants of health, the intersection of behavioral health and long-term services or home care-based services kinds of need, access. Until a year ago, a MassHealth member could change who their primary care provider was every single day, actually several times a day if they wanted to. Now those members are locked in for a year. That's a huge cultural shift for this population. And unless we really address that and understand what their needs are, I worry that as a system, what we know how to do and we do really well, and we do really well in this state, also compared to some other states, is we provide medical care. Medical care isn't necessarily going to be what this population needs. So that's my big worry about the ACA.
Well, and I think sort of feeding off of that, hearing Dan talk about the sort of split of those $16 billion of $10 billion to medical, 1 to 2 to behavioral health, the rest to long-term support services. What that underestimates and what that undercuts is how prevalent behavioral health and substance abuse issues are for this population, and how much that influences the non-behavioral health spend buckets that Dan laid out. When you look at the medical spend for this population, it is hugely influenced by behavioral health and substance abuse needs. And so I think Lisa's absolutely right that for us to succeed, regardless of, and I say us not as Reliant, but as a state, for us to succeed in this, we do have to think differently and much more holistically about how we address the social determinants of health and the behavioral health and substance abuse needs for this population. And that's not something, certainly not something that we've had to do for Medicare by and large. So this is a sea change.
And also the social needs. It's not just behavioral, it's not just diagnostic stuff. It's the chaos, it's the life chaos that needs to be addressed to really be effective with this population. And if you think, I just was looking at some proposals in Kansas, which is very much, their whole focus is how do we get this population back to work, which is what we're seeing from Washington now in terms of the federal waivers. So their entire focus on their new Medicaid program is what can the providers, the primary care and medical providers do for workforce development. Wow, think about that. It's not what we're set up to do, because what they want to do is move people up. Wisconsin has set a lifetime max on Medicaid eligibility in the new waivers. The world is changing, and we've got to think about a different way to manage this. And I frankly think we can do it more cost effectively. And for better care. I think Eric's point about better care for people really is important as well.
Let me address really quickly the issue around behavioral health community partners and some data that I know that Jonathan knows and that we heard at Fallon, which is that the state intends to have a sort of a capitation model for some of the community partners in the behavioral health sphere to care for those with serious mental illness. And it turns out that more than half of those patients or those Medicaid recipients actually have substance use as the main driver. Are we, maybe that's the reason for the addiction coverage, but are we really capable of managing that population? I'd like to hear, you
Sure.
see it every day in the emergency room, so.
I think the answer is we believe so, but we don't have definitive evidence of that. So I'll give you an example of a pilot program we're working on now called MyLink. If you want to find the high utilizers of care in the Medicaid population, go to your emergency departments. We have patients with up to 200 visits a year. And we know them by name, the physicians and the nurses in the emergency department. And typically the last place they actually needed to be was the emergency department, but it was the only place that you can pick up the phone, dial 911 and get a ride to, get a warm meal, right. Get your problem solved. So we put in place a program called MyLink, which was every time a patient that had been in the emergency department more than 5 times in 6 months came in, a flag went up, and not a nurse, not a doctor, but a care navigator, and many of them not even trained at the bachelor's level, would talk to that patient and try to enter them into a program where we would get to the root cause of why they had to keep on coming to the emergency department. And that person would stick with them and continues to stick with them for about 90 days. And they would plug them into existing community resources. They would get them into substance abuse treatment if they needed it. They would get them an outpatient psychiatry appointment if they needed. If there was food insecurity or home insecurity issues, they would help them deal with that. And in that population, we've seen about a 25% reduction in emergency department visits and about a 25% reduction in inpatient utilization. Now, it's a very expensive program that we had anticipated would continue to be funded through the district program right. that you mentioned. And now we're in a situation, do you do this because it's the right thing to do for these patients? Their lives improve from this program, but you're going to lose a lot of money on it. And so, that's our constant conundrum is you've got this mission-oriented activity. It's good for patients, whether it be the care mobile, the community gardens that we do, but the elderly falls prevention, and you lose money on it, but it's good for the community. But you only have so much margin to spend on that. So we end up with we need to do more hearts, more vascular procedures, mm-hmm. more brain surgery in order to support those mission-oriented activities to balance those things off. But I do think there are programs out there that can work on this population. But if you think you're going to take what you did with your Medicare ACO and apply it to your Medicaid ACO, you're going to have a very bad experience, in my opinion.
Jonathan, Reliant actually added a community partner to your board.
Correct.
And you talk a little bit about that.
Yeah, so
a behavioral health community partner.
Behavioral health community partner.
Who's in the audience.
Yes, so we'll give a shout out to Ken Bates from The Bridge, a great organization and one that we've worked with very closely historically, but certainly are doubling down on that relationship going forward. I think going to your question of is there enough out there, for a population with substance abuse issues, quite frankly, I don't think there is. I think there are great developments in this area, and what Eric talked about is a fantastic example of that. But you know, the need is far outstripping the supply of resources, and also the way resources are deployed across the system. You know, there's been a wall historically between behavioral care and medical care, and substance abuse is even sort of off in its own little world in that continuum as well.
Often not provided by physicians and
Absolutely.
And other behavioral health providers.
Yeah, and so as we've looked at our model, I mean, you know, we've taken risk for 4 decades. You know, we have a robust population health structure, but one of the things that we've realized is where we need to be able to do more is around the coordination of treatment for behavioral health and particularly substance abuse issues. And it's not so much in a facility. I think the facilities exist, they do a great job, but what happens afterwards? And you know, I think the program, Eric, that you talked about is one example of how to bridge that. But again, for a lot of people, you know, if you're inpatient for detox, who knows what happens afterwards? And so as we've looked at our DSRIP plan, more than half of the resources that we expect to have available to us through the state DSRIP program will be dedicated to behavioral health services and really behavioral health and substance abuse integration. So building connections with organizations like the Bridge to make sure that we're sharing information back and forth, that we've got defined and clear pathways for care for folks, that we're able to refer people seamlessly for services and coordinate them. What we want to do are things like have some of our primary care nurse practitioners actually be embedded in some of our community partner sites so that, you know, if we're not seeing folks, if they're not coming in for service to Reliant, we still have an opportunity to coordinate with the behavioral and substance abuse side to make sure that people are getting what they've needed. So I think there's a lot more that needs to be done here. I really am encouraged by the fact that this is a focus of the states as well, and you know, think that as we look at the ACO program, we're certainly looking at it at Reliant as an opportunity to break the mold around behavioral health and substance abuse, really do something revolutionarily different, and hope that we can make some change there.
Lisa, can...
So a couple of comments. One is I think there's a huge opportunity to integrate behavioral health, substance use disorder treatment, and primary care for that frontline screening, brief intervention, referral to treatment kind of intervention, or the collaborative care model for behavioral health. I think there's a population, and this is the state's rationale for the community partners, for the more seriously mentally ill or a population that needs more intense behavioral health services. The model that Jonathan describes is really great around that coordination. I worry about the community partner program because I think it's going to require so much coordination across multiple entities. So you have the Bridge on your board, which is wonderful, but that's not the only community partner that your ACO members are going to be working with. And if you're someplace like C3, which is a community care cooperative, which is 15 community health centers across the Commonwealth, I think they have to work with every community partner that has been designated by the state. And what happens is you diffuse those relationships because it's easy. If you're sharing a couple of hundred clients or patients, you learn each other, it's day-to-day operations, but if it's a one-off, it's much more challenging. And so that's something that I think we have to figure out and solve for. I think the other thing is medication-assisted treatment in the primary care setting is going to have to be a standard of care in a Medicaid ACO. It's proven, it's evidence-based. However, there are very stringent requirements around that. So there's a whole policy piece that we need to look at here as well. But if we don't integrate physical and behavioral health, and I would include substance use disorder in that, this Medicaid ACO really is going to be challenging.
When I'm at a dinner party and someone says, well, what do you think about single payer? And, you know, it depends on how many glasses of wine I've had, and then I might get an answer. You know, my concern is not that it's a single payer, it's really that it's a single buyer. And so let me tell you a little bit about investment categories required by the state in the ACOs. Care coordination and care management, culturally and linguistically appropriate services, health-related social needs, clinical integration including with community partners, data and population health analytics, organizational integration, community-based care initiatives, health information technology, and workforce development. They aren't just saying, here's some money, figure it out. They're actually prescribing what it is that are the expectations. And you know, when you have the government as a partner, and this is certainly true with Medicare as well, they really aren't just giving you money. They really have expectations of what it is you're going to do with it. And I think that the DSRIP money, which is how you would develop some of these things, much of the DSRIP money is being spent on people. People who are going to do really important things in terms of integration. But is it a little bit like the apple in the Garden of Eden? Because I do worry when the DSRIP money runs out, what happens to these, to these well-laid plans. So, assuming that UMass does, I think, comes through and comes into the ACOs and so on, you've sort of thought about that as a challenge, I'm sure.
Just the single payer issue. I asked Richard Burke that same question. He said he's fine with single payer as long as it's Fallon Health. Yep. So, I think what the state is doing is more thoughtful and a better program than what the federal government did, in my opinion. Right? They're asking providers and payers to come together to try to manage the overall cost and quality of care. And they're saying when we're going to give you upfront infrastructure dollars to start to do these experiments that you need to do to find ways to bring down the cost of care and improve the quality of care in the lives of the people that we serve. So I think the experiment they're doing is the right one. If to be successful, you're going to have to bring down utilization and over time, enhance care coordination, deal with a lot of substance abuse and behavioral health issues, and be able to make that model work financially without the DSRIP dollars. And that's the big question. Can any providers actually do that? Or is this a program that as the DSRIP starts to fall off, everybody says, we're losing money, we want out. And then I think you revert to, let's talk about single payer again. And the ACO experiment, at the federal level, at the state level, is a uniquely American thing. There are no other countries around the world doing this experiment. And I think that the state's doing it right, but I think there's some providers will fail and get out, and then what? And then what is you reduce eligibility, you crank down the rates because the state has to bring this cost of care down, and you reduce benefit design and what's available. I do think there are some providers that are going to be successful too, and that's where the flexibility comes in. If you can run a tight integrated network where you're connecting those patients to the behavioral health and substance abuse programs that they need, if you're working with your local emergency departments about managing those high utilizers of care, you can be successful and you should be able to continue the program. But it is really going to be about flexibility because one size definitely does not fit all in and around this ACO piece.
Jonathan.
There's a lot in that question.
Yeah.
And sort of a lot of points I'd love to spend some time digging into. Let me start with sort of the DSRIP and the question around sort of the staffing heavy nature of a lot of the DSRIP plans and the sustainability of that. One of the things that we have really focused on at Reliant in developing our DSRIP plan is making sure that there's an evaluative component of it. So if we're going to invest, for example, in embedding primary care nurse practitioners at community partner sites, we need to measure what kind of results we're going to get from that. Are we actually improving efficiency and cost and quality of care for the patients that they're serving? If not, we need to take a different path. And one of the things that we've been clear with the state on, and And I actually am hugely appreciative that the state has been understanding of this. As we've said, there's a lot of stuff in our district plan that, quite frankly, is speculative. We look at this as sort of a grant pool of dollars. We look at it as an opportunity to experiment in different ways to do things that we're pretty confident will prove out to have good results for both outcomes and costs for these patients. But, you know, some of the things we really don't know until we try it. And so for us, as we think about the use of DSRIP funds, evaluating the results are important. If we're not seeing the results, we've got to try a different tack, because we're very mindful of the fact that these funds will not exist in 5 years. And so for us to be able to continue to do this, we've got to prove out a return on investment, both in terms of cost and quality. You know, one of the things that I love about working in Massachusetts, and one of the things that I actually have really appreciated about the process that the state has followed around the MassHealth redesign, is that it has been a collaborative process. And I wholeheartedly agree with Eric that, you know, the level of engagement we've had from MassHealth as we've gone through the ACO, you know, even though there are times that we've agreed or disagreed, and I know certainly UMass has had that same experience, it's been a respectful and open dialogue, and the state has taken feedback from us, which is usually not the case with the federal government. And so as we think about where we go from here, you know, I sort of look at the single payer discussion, and I feel like we've kind of missed the boat. I think people use single payer as shorthand to say we want a system that has more coverage and better access for people. And I don't think anyone disagrees with that. I think because of the environment we have in Massachusetts, I think we're able to talk about what those goals are and think about different ways to get there in a way that is more productive than it probably would be at the federal level at this point. And so one of the concerns that I have for you know, for the program here, and one of the hopes that I have, is that if we can be successful and if we can be adaptive and show how this will work in ways maybe that are not quite what we envision today, but if we can kind of continue moving forward and making progress here, maybe we can be a model for sort of a smarter and more productive discussion around how to improve access for people across the country.
So I think one of the things that that the state did right on the DSRIP dollars is you get the most dollars in years 0 and 1, and then the dollars decline over the 5 years. So you have to learn to wean yourself from the big dollars, and they're pretty big in the first couple of years, down to lower dollars over time. New York did the opposite. I have no idea why. They started with little dollars, and by the end of the 5 years, you get all the dollars. And so I think that's a really important component, but I do worry about sustainability. I mean, programs like Eric described for high ED utilizers are great, but if you can only touch 25 to 30 people, you can't just keep hiring increments. Even if they're at $30,000 to $35,000 in FTE, you blow your budget overnight. I agree with what Jonathan said. I think single payers become shorthand for something else. I think what we do need is more standardization. And we talked about standardization in the care delivery system. I think that what makes providers nuts about the multi-payers is there are 15 different quality measure slates. There are slightly different variations on that theme. The benefits are a little bit different. The prior auths for this plan are different than they are for this plan. I don't think it's so much about whether I'm come in with a Fallon card or a Health New England card or a Blue Cross card. It's around the fact that there's all this complexity that goes along with that. And that simplification, and even in a couple of areas, I mean, if it were around, if we could come up, for example, with a standard drug formulary, that would also help when people change insurances. Or if we could come up with a standard quality measure, think about how that would help with building data and information exchange, because we'd all be looking for the same stuff. It also, frankly, I think would really improve the care of the people, because right now, if you're measured when you're in a certain plan, you're not measured over the course of your life. And but that's my...
So here's the really bad news.
Yeah.
We have, Fallon has 3 ACOs with which it's now contracted. Those are 3 different products. Never the twain shall meet. And they'll all have those of the 1.3 million letters that Secretary Tsai talked about. The network is the network. It's narrow. and it's controlled in a narrow fashion. So I think that is another one of the real challenges. Before I get to sort of where each of you, I'm going to ask sort of if you could do one thing, you know, sort of the crystal ball. I do want to come back to a point that Dr. Dickson has made a number of times, and you know, when Secretary Tsai talked about commercial payment and Medicare payment and Medicaid payment, I think that, you know, I think people understand that part of what makes this reform viable in terms of potential success is the unit price, because the unit price has to be low. It has to be as close to Medicaid as what Medicaid, because that's how Medicaid is paying the providers. And I think that this is another another huge challenge, and it's certainly a challenge for an institution like UMass, which is a safety net hospital. So do you want to just?
Yeah, and I think the only way you can have a unit price that is higher than what is booked into the rate is if you have a utilization that is lower than what is booked into the rate. And for us, a tertiary care facility that has to maintain a trauma center, a level 3 NICU, teaching services, is mandated to support the state's medical school and fund a significant portion of the state's medical school. We can't live on the base rate for Medicaid, and unless we have a high commercial volume that would then subsidize that. So you know, we have to, for us to make any of this work, you know, we have to find a way to work on utilization as the way to be able to up the base rate, because the base rate is just completely unsustainable for us, especially as you see people aging out of commercial into Medicare programs, and then people leaving commercial, many of which are employed and going into the Medicaid programs. It becomes harder and harder to accept that. So it does require a different relationship between the payer and the provider. And the beauty of the ACOs is that you're aligned, for, you know, and some of the competitive nature and the angst goes away because you both are trying to work to drop that utilization once you've agreed upon the rates. So, and that's why it's an experiment that may work. One of my biggest fears, though, is I hear about the disrupt and cranking it up front, is you're going to build all of that expense structure into your company. And as that goes away, you don't just have to get back to where you were. You need to be able to cover all of that new expense. And it's not like just walking away, you're back to where you were. And for us, we looked at the same thing. You're in a worse situation than you were, because now you've got dozens, maybe hundreds of people on your books doing this work that you don't have funding for. And so it could work to the negative.
Anything to add to that? I mean, this was directed at, you know, to Dr. Dickson on purpose because of the.
Well, one thing that I would add is, you know, being an ACO, you're kind of in this strange place where you are both sort of the payer and the provider in the relationship in some ways, and so I think as the provider, we feel a lot of the same pressures that Dr. Dickson did. As the payer, you know, we are trying to manage costs towards a budget that is based on Medicaid rates. And in fact, for an organization like Reliant, because we are historically efficient and our costs are lower, our budget takes a further hit based on the state's methodology. So the state basically went through and said, depending on your historic efficiency, we're either going to pay you a little bit above a capitation rate that's based on Medicaid, or a bit below.
That was a fun conversation we had with Reliant when we showed it to them.
This was concerning to us because we're actually taking a 10% hit on our capitation rate in the ACO. So for us to be successful, not only do we need to be able to pay out Medicaid level unit costs, but we somehow have to figure out how to manage from day one to keep costs at a level that are 10% below the historic average in the region. And so we're kind of starting at a place where you've got to be working really efficiently even to get to break even. And so I think, you know, as we look at the structure, you know, one of our long-term concerns is, you know, the state has a very genuine and very important interest in holding down costs in Medicaid. And I mean, you know, we're all taxpayers in the room, we all get that. But, you know, when you're on the other side, you know, I think you have this constant fear that, you know, if this doesn't work, there's just not enough money in the system for it to go around. And, you know, God help the patients that we're trying to serve if this doesn't work and we can't continue to provide those services.
So let me just, as sort of the last question, if you could do, I'll start with Lisa this time. If there's one thing that you could do, the magic wand, to help manage costs and improve the care. Just a little question.
Just a little question.
Yeah. Well, only take a piece of that if you'd like.
I think it is around really incenting people to use primary care effectively. And when I say people, I mean not just the patients or the clients or the members, whatever you want to call them, but also the providers, to think about when you refer, when you don't refer, to make the patient experience the best that it can so that people don't go shopping. I mean, the one thing I'd love to do, but I'm not this powerful, is redo how the RUC pays for services. I mean, Eric said it earlier. You get hearts in, you get transplants in, you get paid really, really well. You do really great preventive behavioral health, primary care, SUD treatment, you get paid really, really poorly. So if we could flip that, that would probably be the one thing that I would do.
So I love that idea, given how our organization works. You know,
Dr. Dickson's got a lot of vascular surgeons and neurosurgeons.
we have a few of those too that probably would appreciate that
Hey,
answer.
I worked in a major academic medical center.
Yes, we know.
You know, I think for me, if you look back historically, there have been too many silos in the way that care is provided, particularly around the medical side of the benefit. And Lisa talked about this with regard to the social determinants of health. We've talked about it with regard to behavioral health and substance abuse. I feel like that's set us back in a lot of ways. And, you know, as I look at, you know, where healthcare is going, I'm not really concerned. I mean, I'm a little concerned, you know, about sort of the medical side of things. But, you know, at the end of the day, we know how to be efficient in that space. And we've got tools and we've got initiatives in all of our organizations to do that. What we really have not figured out in our system, and certainly within our organization to the extent that we would like to, is how do you integrate in social determinants of health, behavioral health, and substance abuse into a medical care model. That, I think, is the biggest challenge for us going forward. It's going to take a huge shift in terms of how we as providers evaluate ourselves and how we look at what we do and look at sort of effectively our job descriptions as we're caring for patients. It's about so much more than just providing care to that patient at the time, and I think that's the biggest thing that, you know, we're now as a system trying to fight to get back to something that is more holistic, that is more integrative than it's really ever been.
Lisa completely stole my thunder, and
Sorry.
You know, how you pay for care has a profound impact on how you deliver care. It's just unquestionable at this point. And in the United States, we pay for procedures, we pay for interventions at a far, far greater rate than we pay for coordination. You know, we see primary care getting paid, the gap between primary care and specialists being so large, and the only thing that's bigger than that is the gap between outpatient psychiatrists and the specialists. So I like tweaking the system slowly over time, and I think you take a 1% away from procedural lists, not just the doc side. It's not the doc side, it's what the hospital gets paid for those procedures, which is a lot more money than the doc side, and start to shift that to care coordination, primary care, palliative care needs much more outpatient psychiatry, And I think over time you'll have a system that looks a lot more like the rest of the world and has a cost structure that's a lot more like the rest of the world. And I think the FQHCs do a great job of that, but they're very underfunded. So take a little bit away from the proceduralists and give it to the FQHCs, give it to the palliative care specialists and the cognitive specialists, and I think things change over time.
Yes. Yes.
You have a microphone.
Oh.
Hi there, thanks everyone, this was really fascinating. I'm gonna ask Lisa for another more one thing question. So I work with Jonathan at Reliant, and I actually in my career spent about 17 years working in community mental health centers, and the last 10 and a half working in medical services. And to Jonathan's point, we at Reliant really know how to do primary care. And we've distinguished ourselves, we're great at primary care, and I've witnessed community mental health systems that are really great at doing what they do. They have robust systems, they're comprehensive. I think one of the biggest challenges about the ACO, as we've all alluded to, is getting these two systems to work together, because they've worked beautifully as silos for decades. If you had to say one thing that we could do at Reliant, that would, the biggest hill we have to climb, or the biggest sacred cow we need to get rid of, what can we do to facilitate that connectivity better?
So I started my career in community mental health as well. So I think it's taking off a little bit on what Jonathan said. We have to think about the roles differently. And it's around how do you really collaborate and work together. I worked in 2 different health centers. One shared the behavioral health record with the medical providers and the other one didn't. I think that is really critically important. And I think as a clinical social worker, at least I was trained that way, I need to be able to understand that what I say in the record is important for the primary care provider, and I have to allow them to have access. And I think there's a lot of resistance. I also think in behavioral health, we need to move to a more evidence-based, goal-oriented kind of treatment than at least what I was trained in, which was sort of more the long-term psychodynamic psychotherapy. I'm doing a huge project right now in the state of Delaware, which is all around behavioral health integration, both in primary care settings, but also putting primary care providers in community mental health centers. And we are creating metrics for success, and if you want, I can share them with you offline. Yeah.
Other questions? Peter.
Yeah, I have a 7-part question that I'll get down. I'll get down to 2. The first one is, Dan talked about that migration of 300,000 to 400,000 people onto the MassHealth program. And Eric, you mentioned that's sort of partly a mix of people leaving commercial insurance, and then just sort of a reflection of the baby boom demographic, just more people retiring. What is that a trend that continues on? Is that continues to be a bigger problem for the state? And when you talk about getting paid, and this is more for Eric, and Tom, you drew this chart that said the payments are here, here. Is that like a dollar commercial Medicare and Medicaid? And I ask this as a non-healthcare person. Is that $1.98 and 95, or is it $1.80 and 60 cents? In a very simplified view, what is the scale of that?
Yeah, $1.30, $1.70. So you can make it work if you have one Medicare, one commercial, one Medicare, one Medicaid, which is right where we're at. As soon as it goes beyond that, you see hospital closures. We had the governor here just a few days ago when he was Secretary of Health and Human Services. He had the payer mix for the hospitals in Massachusetts on his wall, and as soon as you got beyond 66% governmental, you closed. And so your Sims Hospital, your Choate Hospital, your Sancta Maria's, just a long list of places I worked at 20 and 30 years ago that are all gone, North Adams. As soon as your governmental payer mix hit goes over that 66, you're doomed. And we live on that right now, and with a near break-even margins. So it's tough.
And the coverage in terms of commercial insurance has, over the last 10 years, has dropped from 65, 66% down into the 50s in Massachusetts. And we're a very high, obviously a very highly insured state, so you can see what happens in other parts of the country.
Yeah, Pittsfield's going to be a challenge for you.
Yeah. And we have friendly insurance in Massachusetts. I mean, we have much more provider-centric insurance than in many other states across the United States. Or homegrown insurance, which I think really has also changes.
Yes.
I'm medical director for Pediatric at Reliant, and this has been a great discussion. So it's more a comment as a pediatrician. We have an ample body of evidence that adverse childhood events have a strong impact on adult health with chronic illness, substance abuse. We know how to screen for that now. We know that early intervention in children can make a difference and change the trajectory. The problem is we'll see the results 5, 10, 15 years from now, or most of the return of investment, if you will. But I think the time is now. The evidence is there. We don't need to do more studies. There's been thousands and thousands of children study and follow, and it's as strong as it can be. But I think we need to start at some point, and I think the time is now.
We have a program for treatment of pediatric patients in the schools with asthma. And you think about what happens if you've got a kid with asthma that can't go to school. Mom can't go to work, especially if they've already got challenges paying the bills. Sometimes the parents lose a job, the kid falls behind in school, and what they really need is treatment of chronic care disease, and this impacts them the rest of their life, educationally and in terms of their overall wellness. A less controlled asthmatic that, as a child, does worse as an adult as well. Another program we're going to fund with DSRIP dollars that we'll have to look for a way to try to fund. So, I think that there are things that work, and the problem is fee-for-service doesn't fund them. And fee-for-service works just fine for 95% of the people, right? But for the 5% that utilize 50% of the healthcare resources, it's about care coordination, it's about at home, it's about somebody that calls you on a daily basis, make sure that you can get to your appointments, and that's where we need to be making the investments. And with the DSRIP dollars in the ACO, there's an opportunity to do that. That's why, despite not participating, we're excited to watch the experiments go on and see how people do with that. But we didn't have to do ACOs to do that, right? We could have done that through funding those fundamental programs like asthma care in the school systems without having to create an overhaul. And I'm a incrementalist. There are relatively small changes to the system that we can make that will have a profound impact over time. The problem is they take 10 years, and we better start now if we're going to do that. And I think we won't be starting now because of what's going on in the federal government, and even because we're doing this experiment here in the state. We need to be investing in those types of programs, especially early on with kids, and not making it dependent on whether or not that kid's in an ACO or not. Because theoretically, now you've got a kid in the Fallon Reliant ACO, and maybe you'll do that type of program for them. Then you get the kid sitting next to them that's not going to get that, might have the same disease. It needs to be for everyone.
Lisa mentioned TANF, and of course there's the CHIPS, which has not been reauthorized. And half of I think people know that half of the kids in the United States are cared for really through Medicaid, and 40% of the deliveries in the United States are covered by Medicaid. So, the state involvement in this incredibly vulnerable time in a child's life and in a mother is absolutely critical.
Can I make one other comment in terms of change? I think the other thing we really have to think about is the silos that we've created in the delivery system. So I've worked in places where I've had physicians say to me, what do you mean the medical assistants can do a depression screening and say that they need to be referred to a behavioral health provider? I want to do that. Or I've had people say to me, a conversation I had just yesterday in another state was, well, what do you mean that when the person gets discharged from the hospital, only a nurse can talk to that person? We really need to examine our own biases around that and really think about what does the person need? And there are absolute scope of stuff that is not transferable across disciplines, but there's more that's transferable than I think we are actually willing to think about if we really think about it. I mean, and you know, health centers, for example, have a waiver now where medical assistants can give some immunizations within the health centers. That's an incredibly effective way to deliver care, and it's cost effective, and it doesn't take away from nursing's important role with the population. But I really would challenge us all to think about that.
And I think we're going to be forced to think about that too. I mean, I think when you look at the workforce demographics, I mean, we have an aging population that includes our own providers, that includes our own staff. Again, this is one of the reasons why at Reliant it's been so important to us to look at team-based care, because at the end of the day, you know, it's going to be really hard to find qualified physicians and nurse practitioners and nurses, and we're going to have to think more creatively about how we staff ourselves to make sure that we can care for the patients that we have. It just, otherwise the system is not going to be sustainable.
Yep.
Anything else? Oh, there's one. Okay.
Hi, and this has been very, very informative. Thank you so much for providing us today with the Business Journal and for our speakers, our panelists. My name is Jody Justepin, and I'm the Vice President of Marketing at Essentia Health Alliance here in Worcester. And we serve predominantly the underserved. So we're seeing a lot of what you're talking about here with regard to ACOs and the Medicaid population directly in our client base. So my question to you is, there seems to be really an opportunity to help with upstream care services that will help prevent downstream care costs when getting this population to the care that they need and remove the barriers that they're experiencing, and that may include language or cultural issues, as well as transportation and even workforce. So where do you see, or how do you see getting social services more embedded into the ACO model so that we can help prevent some of the downstream costs by addressing some of these upstream healthcare needs?
Let's see. Please come talk to me and let's connect. We absolutely have to do that, and I think it starts with making sure that we have connections and relationships with the organizations in the community that are doing that work, and we start to think about ourselves not necessarily as you know, sort of referral relationships in the community, but really as part of an integrated whole. I mean, that's ultimately where our vision is as we think about the ACO. That's where we need to get to in terms of thinking about partners in the community. So absolutely, I mean, it starts with developing these relationships and then figuring out how do we truly integrate, you know, our teams and our operations so that we're working for the same purpose.
Okay.
Boy, I think, you know, we made a promise at the beginning, and I think this group really delivered. Thank you, Lisa, Jonathan, Eric, and Tom for a wonderful conversation. Thank you also to our presenting sponsors, Fallon Health, Reliant Medical, there they're going to go flying on the screen there, Reliant Medical Group, UMass Memorial Healthcare, supporting sponsors, Conover and Gould Strategy Group, Anthony and his team from Revelation Productions, there he is in the back of the room, thank you, Anthony. I want to especially thank, I think most people in the room run into or talk to Chris Prosser at the Worcester Business Journal, who does a fabulous job making these events happen and making it easy for everyone who's involved. So Chris, where are you? Would you stand up? There she is, okay. And our team at the WBJ, the Beechwood, Curry Printing, Elevation Exhibits, Mark Serra Production, and of course the fabulous Ron Belay, photographer, who's already got some group shots. He might shoot one more. That's it. We're done before 10:30. Thank you so much again to this great panel. Thank you.